Hello and welcome to Vital Discourse. Today we're going to talk about rhinoplasty, a nose job. What are we going to talk about? Well, we're going to first talk about, who's it indicated for? Why do we do it? There are different reasons you can do a rhinoplasty. We're going to talk about how it's done. We're going to talk about the pitfalls. We're going to talk about recovery of rhinoplasty. And we're going to talk about things like insurance. Does it cover rhinoplasty or doesn't it? We're going to go into all of that today. Stick with us in our talk about rhinoplasty. So, Dr. Ben, we're going to talk about rhinoplasty. You and I are both trained facial plastic and reconstructive surgeons. We do a lot of rhinoplasty. There are a lot of different ways to do it. First, can you talk to us about who may or may not be a candidate?
Well, I mean, look, everybody considers themselves a candidate. It's a lot more subjective than the objectivity behind the decisions in septoplasty that we talked about last week that have to deal with mostly nasal breathing. This is partially nasal breathing, right? So everyone can consider themselves a candidate for rhinoplasty, right? Whether or not your surgeon agrees with you may depend on the surgeon, and it may depend on what criteria you were using to come up with the idea that, yeah, I need a rhinoplasty. So it's very subjective. It's a team approach, and that's why you want to shop around for your doc. And in general, after you've figured out if they're board certified and they know what they're doing, you like the before and afters, do you get along with them? Do you guys think about beauty the same way, right? If they morph your nose and you say, I want a pretty nose, do they come up with a nose you think is pretty? These are all great ways to figure out if you're a candidate. There's also health concerns, are you able to go through surgery, things like that. But in general, it's a team approach, and you got to feel comfortable with the person that you're choosing to have done.
So someone decides, hey, you know what? I don't like the way my nose looks. It's too small, it's too big, I can't breathe out of it as well. What is your process of going through your assessment of that person? How do you tell them you're going to go about doing a rhinoplasty? Where do they go?
A little bit of a deceptively simple question.
People often say I'm deceptively simple.
Lee is deceptively simple. The funny thing is, the first thing you have to do, so that patient is trying to figure out if you look at beauty the same way. You actually, as a surgeon, have to figure out, are they seeing the same problems I'm seeing? And if they're not, is it a sign of BDS, body dysmorphic syndrome, the sort of scary thing that leads people to not see themselves properly, and instead of an indication for surgery, it's an indication to maybe have them talk to somebody and figure out why it is that they believe that their nose has been responsible for them not getting ahead in their job or something like that. So if they're telling you, I always ask them, what don't you like about your nose? And if they're saying things that I'm looking at and I do not see at all, I start to question further and figure out if they have BDS. But let's say that I totally agree with what I see. And then I start to form an opinion about the nasal function. Why do I do that? Because rhinoplasty can sometimes, in the post-op period, because you're reducing the nose in general, it can sometimes cause some difficulty in breathing if you're not careful. We'll talk about that in a little bit. But so you want to make sure that they don't have any underlying problems like a deviated septum or nasal valve collapse or problems that we're going to get into in the post-op period that might make it really difficult to breathe. So you don't want to make sure you're not falling into a pitfall. And then I start to think about what I would do to change the nose. Is it hang down too much? Is it projected too much? Is there a big dorsal hump? Is it twisted off to one side? All of these are classic problems that people come in for, and I want to identify those, and I want to make sure that I have experience in treating all of those things so that I'm going to get the result that I know that they want. Then I'm going to try and put their picture into a program and morph it or change it so I can give them a reasonable approximation of what it might look like if I do the things that I want to do in the best way possible, and we have a great outcome. And then I want to make sure that they agree.
I want to pick up right there as an attorney. I think that we need to be very careful with those morphing programs. And the reason is that there has been litigation based on those morphing programs where people have been shown what their nose, quote unquote, will look like afterwards. And you can't necessarily do with your hands what you can do with a computer program. Right? So we've got to be very careful.
Do you use a program?
I do not. And look, I'm an attorney. I do not use a program specifically for that reason. I let my pre-op and post-op pictures talk for me, speak for me. I let my years of experience speak for me. I let the fact that the vast majority of patients that come to me for rhinoplasty have been referred by someone else who's seen someone or talked to someone that had a rhinoplasty by me. And that's the way I do it. But I specifically don't want to put in someone's head that I can do something that I might not be able to do, because as you and I both know, the best intentions, the road to hell is paved with good intentions. Your best intentions might be able to make the nose look like this, but once you get in there and you see something that might not let you make it look like that, it could be a couple of millimeters off, and there's no way you can make that change. That's going to be very, very upsetting to a patient after you've shown them something that made them look a specific way.
I do something a little bit different, somewhere in between. Mirror, which is probably currently the number one program out there to change the nose to help sell a surgery. I don't use it, and I don't like it specifically for that reason. And it also gives them a printout, and you can put on there all you want that this is, for information purposes only, or this is not real. But if you give it to them, they're going to take it as real. So I use Photoshop. I tell the patients this is completely unreal in that I'm just moving pixels around. And I focus mostly on the side to let them see what they would look like if their nose was changed, because I do think that they need to get used to the idea of a different profile and a different look from the front. But I don't let them take it. I don't let them take a picture of it, because I don't want them to focus on it as though it's real. So I'm somewhere in between. I want to make sure that they're not putting all their hopes on that. I also have that written into my consent form.
So let me ask you this. Patient comes in with a picture from the magazine, says, I want to look like that. What do you do?
So, Lee, I've changed on that quite a bit in the years. I used to think it was a sign of body dysmorphic syndrome. I actually, as long as it's realistic, I mean, look, if a girl from Northern European stock with a really leptorine, thin nose, tall nose, brings in a picture of a Swahili woman with a really platyrine nose, I'm going to tell them something's wrong here. That this is impossible. We can't really get there from here, right? But if they show me the kind of nose that they're talking about, I will question whether or not I can never get you somebody else's nose. This is your nose. And so your nose is going to look like a variation on your nose. But if they're trying to describe the tip that they want and they show me, and they realistically understand that I can't give them that person's nose, but they do want it to. They don't know the words of more rotated, less rotated, more projected, less projected, and it's easier for them to show me. It's like a pictogram, right? Then I like it. What about you?
No, I would agree with you completely. So there's an old saying in rhinoplasty, you can't make chicken salad out of chicken shit, right? So you have to work with the building blocks that you have. And sometimes the building blocks that you have are deficient, right? We can borrow cartilage, we can borrow tissue from elsewhere and try and build, but to make something look exactly the way something else looks might not be the easiest thing in the world to do. So there has to be a caveat there that I will try my best to make your nose look as much like that nose as possible, but understand you are not going to look like that person, right? You are not going to look like Jennifer Aniston. You are not going to look like whomever the picture it is. Your nose will look similar, But you are not going to look like that person. And guess what? You're not going to be on TV either because of it. because of the
Right. And you're not going to marry Brad Pitt. Right. So, but with that said, then so what is rhinoplasty for? What can it do for you? What is it not?
So what it can do for you is it can change the shape of your nose, and that change in the shape of your nose might be more aesthetically pleasing to you, more aesthetically pleasing to others. What does that do for you? It can increase your self-confidence. Absolutely 100% it can do so. Is it going to change your personality? It might. Sometimes it does change, makes people feel a little bit more outgoing, feel a little more comfortable in social...
It's a self-esteem issue, Lee.
Yeah, self-experiences and social experiences, I should say, and that type of thing. So it can have some of those types of benefits. But again, like I said before, is it going to make you more popular? If that's what you're doing the rhinoplasty for, we would have to have a discussion about that. Is it going to get you the job that you've always wanted? Maybe not. We're going to have a discussion about that. So there are limits to what an improvement in your facial appearance can and can't do. And I feel uncomfortable when someone comes in and says, my life is horrible, I'm terrible, I feel like I'm nothing because my nose is too big. And I want my nose to look like this person's nose so I can have a better life. If your nose is what's going to make you have a better life, we have to have a really strong discussion and a relatively intimate discussion about what's wrong. What do you feel is really going on in your life that your nose is the issue for you? And to that extent, facial plastic surgeons do end up having some psychological training because we have to deal with these types of issues.
How many people would you say you turn down for a rhinoplasty, for whatever reason, out of 100 patients that come your way looking for a rhinoplasty specifically?
Part of it depends on what the type of rhinoplasty they're coming in for. Revision rhinoplasties, I probably turn down 50%. And usually what happens is it's someone that had a rhinoplasty within the last year by another surgeon, and they're unhappy with this, that, or the other thing. And then I say to them, well, what did the other surgeon say? And the other surgeon said, well, it's only been 6 months since your procedure. Let's wait another 6 months because it takes a year for all the swelling to go down and for what Frank Kamer used to call the vagaries of healing to take place to see what we're left over with. And I will not operate on that patient, absolutely 100%, because I would want to have the same courtesy shown me by another surgeon that if there's someone that's in the early postoperative period that's yet to see their final result, to see if there needs to be anything further done. So
absolutely. That's just etiquette.
That I will refuse. Obviously, I would say that maybe only about 10% of the patients that I see looking for rhinoplasty would I turn away because the expectations are so unrealistic that I can't even convince them that the rhinoplasty is not being done to change their entire life. And then the others aren't necessarily turn downs. It's more just, this is what I can do and this is what I can't do. And sometimes you'll get people that will doctor shop and just look for someone that will say, I can do that, even though for the most part it can't be done.
Great points, man. Great points.
So the thing that I'd like to ask you is, to what extent does the functional aspect of the rhinoplasty, making sure that people can breathe better or fixing the breathing issue at the same time as the rhinoplasty, how does that change what you do and how you approach it, number one? And number two, if someone has a deviated septum, whether or not they're congested from it or they're having symptoms from it, is it a requirement to straighten that septum when you're doing the rhinoplasty?
Great questions, and all of them super loaded. I'm going to start with the septum first. So the septum is a quadrangular shaped cartilage. One of the fallacies and myths about the nose is that it goes up your nose with a rubber hose, right? No, this is a blind-ended sac up here. The nose follows a straight path from the nostril back to the ear roughly and down. And so that septum starts here, but it also forms a quadrangular shaped sheet that gives our nose the beautiful L shape from the side, but also goes far back, 7 centimeters, 8 centimeters into the nose. And so if it's vastly crooked, sometimes it can determine how the nose is shaped, how it comes off the skull base, whether it sits to the left or the right, whether it's hooked or C-shaped. The septum can have a drastic effect on the outcome of the surgery, and if you don't correct it, you're not quite going to get the patient to where they wanted to go or expected to go. Bring the nose completely to midline. Straighten the dorsum of the nose. This is the dorsum. So you have to really assess, is the septum truly a problem cosmetically? So even if they tell you, first of all, are they saying they're asymptomatic, but they're snoring, having ear pressure, and have chronic sinusitis? You have to determine if they're just not aware of it or if they're truly asymptomatic. Once you know that they are asymptomatic, is it a cosmetic problem? Well, then you're going to straighten the septum anyway.
Yeah, Bill Lawson used to say, as the septum goes, so goes the nose. So in my training, the septum was always straightened. Remember, really the classic name for the procedure was a septorhinoplasty, not a rhinoplasty.
Correct.
And what I find fairly often is people that had their previous rhinoplasty by someone who was not a facial plastic surgeon.
General plastics.
Right, that the septum was just avoided. They just ignored it.
To my point before, though, Lee, if you have a severely deviated septum but no symptoms, remember, you're tailoring these cartilages. You're making a 3-bedroom house out of a 5-bedroom house. So if that wasn't significant before, it could become critical afterwards. So my penchant is, and I think this is where you were going, because we're ENTs, we usually wind up fixing it.
Yeah, and to your point, you could create a problem that you don't know you're going to create. So the 2 buckets that I see are, bucket number 1 is the person that did not have nasal obstruction before their rhinoplasty and has it now because the septum wasn't corrected, or there was the way they treated the side wall of the nose, the cartilages of the side wall of the nose was over resected, and they're collapsing. And the second bucket is those people that it looked great right after the procedure, but the bones started shifting to the septum over the ensuing year. That everything started out right in the midline, and next thing you know, the dorsum, the top part of the nose, has shifted over to the septum. And like I said, as the septum goes, so goes the nose.
Yeah, absolutely. So we know that it's well known, actually, should I say, that the rhinoplasty is one of the most difficult surgeries that we do as facial plastic surgeons or head and neck surgeons for a variety of reasons. Some of those reasons are obvious. Well, it takes a lot of skill to open the nose. That there's nothing wrong with the nose to begin with. It's just not shaped like we want it to. So you're going to take this nose that's normal, you're going to make cuts on it and make changes, and then you want it to come out well. That's the technical aspect of it. Then there's the healing. So Lee trained with Frank Kamer, and I trained with Calvin Johnson, who were both very good friends, by the way. So I have, as Calvin Johnson's disciple, I have a lot of Frank Kamer stories, and I'm sure vice versa as well, because they figured out the deep plane together.
I know Frank Kamer because he trained at Sinai, where I trained, but I actually trained under Bill Lawson and Ferd Becker.
Oh, okay, great. Yeah, no, I the same thing happened to me.
Closed rhinoplasty expert, open rhinoplasty expert. So a little of both worlds.
Yep. No, well, actually, I was in the Navy, and we should get into training a little bit. I was in the Navy, and so I trained with Calvin Johnson, sure, but the Navy's great. They'll give me temporary additional duty to go and work with whoever I want to. So I spent a couple of months with Vito Catella up in Rochester, New York, who's a god in facial plastic surgery, and Dean Toriumi, who's recognized as one of the world famous world experts on everything in the nose, all the types of approaches. But I guess what I'm getting at is, look, no matter where you come from, you have to deal with the idea that we're all probably well technically trained, but the nose is hard to work on because the nose doesn't behave itself while it's healing.
The vagaries of healing.
The vagaries of healing. And well, the way Dean Toriumi used to put it was, this surgery will break your heart because you'll do everything right. You'll make all the right moves technically. And at 1 month, it looks great. And then at 6 months, it'll be off. Part of that's the bone. Part of that's the septum. Part of it is the fact that cartilage doesn't behave itself while it's healing because it relies on diffusion for oxygenation. So that means that the tissue laying over it keeps it alive. The bone has its own blood supply internally. That cartilage does not. So if you have a little bit of a layer of blood on one side, the cells on that side are going to die, and guess what? You're going to twist to that side. And it won't happen right away. It'll happen 6 months from now. And both of you will be wondering, what the heck happened? What did I do? After 45 years of practicing, Calvin Johnson still had a 3 or 4% revision rate. And he's arguably one of the greatest rhinoplasty surgeons who's ever lived. So it's tough. Well, with that said, what do we expect? What do you tell patients during the process? So we've decided who to operate on. We've decided what to do. And now we want to talk to them about what to expect and how to get over it. Go.
So first thing is just when we're doing rhinoplasty, when we're performing rhinoplasty, especially when we're doing tip work, we tend to tape the nose, okay? Why do we tape the nose? We put tape on the nose and we pull the tip of the nose up with our tape. What are we doing? Well, we've made incisions inside the nose. Those incisions inside the nose, the edges of the incisions need to stay together. If there's anything that pulls on those edges, what's going to happen? You're going to get scar tissue at those edges, and you're going to get either nasal deformity or you're going to get nasal obstruction because of it. So we like to hold those edges together by using our tape to keep the nose in place. The other thing that the tape does is it gives us a little bit of compression, as well as a nasal cast or a nasal splint over the top of the nose gives some compression. So the first thing I say is, once we take that off, your nose is going to look completely different than what it's ultimately going to look like. Why? Because your tip is going to rotate back down over the ensuing week or two. You tend to get a lot of swelling right at the top of the nose when you put splints on, because the splint squeezes the nose a bit here and it creates a little dead space over here. And so you get a lot of swelling that just sits at the top of the nose. So the first thing that I say is, don't worry. You're not going to end up with a pig nose. Don't worry. The top of your nose isn't going to stay this high. Okay?
What's wrong with the pig nose?
What?
I raise pigs. What's wrong with a pig nose?
So the next thing is, how long are you going to be black and blue? Presuming that I broke the bones, you get some black and blue here. Usually the black and blue will last anywhere from 3 to 4 weeks. That's going to depend on the color of your skin. If your skin is darker, the black and blue is not going to be as noticeable. If your skin is lighter, it's going to be more noticeable and might last longer. Some people use things like Arnica and that type of thing. I really don't find that those really make much of a difference, but by all means have at it if it makes you feel better. The swelling, I tell people it takes a month for 50% of the swelling to go down, 3 months for 75% of the swelling to go down, a year for all the swelling to go down. You'll notice subtle changes in your nose over a year's period of time. That's kind of the basic mantra that I go through.
Do you give steroids?
I do give steroids because I do like to decrease some of the swelling afterwards.
Yep.
I find it helps somewhat. It might help with a millimeter or so with the swelling, but look, rhinoplasty is a radical procedure. There's a lot of swelling afterwards.
So do you ever recommend hyperbaric oxygen?
I only recommend hyperbaric oxygen if I'm doing an open rhinoplasty, which I usually do in revision cases. And if I'm doing an open rhinoplasty, for those who don't know, open rhinoplasty, you're making a little incision here and you're peeling back the skin. When I do that and I peel back the skin, if I have to graft the tip, and then when the skin comes back over, it's over any tension and there's even the slightest discoloration of the skin of the tip of the nose, I'll have them go through several hyperbaric oxygen dives to make sure that there's no loss of the tip of the skin.
Just as an aside, do you ever use nitro paste instead of as a first line instead of giving them the hyperbaric oxygen treatment?
You can only see a bad result if you lose that tip skin. And therefore, I do everything. I don't try and then say, well, if not, I'll go here. If I feel there's any compromise whatsoever of that tip skin, they're getting Nitro paste and hyperbaric oxygen.
Oh, so you do both?
Yes.
Yeah. I have. Do you have a hyperbaric oxygen chamber in your office?
I don't, but a colleague of mine does.
I have one in the office. I use it for everything, and I can tell you that you give a little bit of steroid, a little smear, a little shtickle of nitro paste across the tip and across the base of the columella, you get dramatic reduction in swelling in the first week. Dramatic too, and you can tell in the breathing as well as just visually on the face. It's not everybody wants to do it, not everybody can do it. Just because a doc doesn't have access to a hyperbaric oxygen chamber doesn't mean they're a bad doc. Not everybody can go through it because you're going down you're up in atmospheric pressure down in terms of a dive, and you have to be able to clear your ears. With a nose, it's a little bit difficult because if you have to hold your ears on your nose and pop your ears, that might not be possible after a rhinoplasty. But if it is possible, really helpful.
How many dives do you usually do?
I will offer 10, but 5 is the minimum. And it's usually about an hour, and it's about 1.8 to 2 atmospheres, usually 2 atmospheres, no more.
So, Dr. Ben, is rhinoplasty only done for cosmetic purposes, or are there other reasons to do rhinoplasty?
No, what it's come to be known as rhinoplasty is certain approaches or a level of complexity to the surgery that you're doing on the nose. Make no mistake, you can do an open septoplasty. You can lift the skin up to come down on the top of that septum. So it's not just the approach. And there are, as you pointed out before, there are closed approaches. There are open approaches. And then there's the whole new concept since 2018 of preservation rhinoplasty. That could be a whole show on its own. Rhinoplasty has become associated with the cosmetic procedure to make your nose look different. But there's actually a whole other side to it. It's a level of reconstruction that's designed specifically to help your breathing, and they call that functional rhinoplasty. So the designation is cosmetic rhinoplasty versus functional rhinoplasty. That's things like nasal valve reconstruction, which was an early episode of ours. And that's trying to combat somehow the instability of the nose. There are some non-surgical approaches or minimally invasive approaches, but the surgical approach is a part of a functional rhinoplasty. Also, putting in different things that you might want to do, supports to the columella, this crazy little lobule that people pierce every now and then hanging down here. The sidewalls, like we talked about, straightening out the top of the septum, both cosmetically and getting it out of the airway in an open septoplasty. All those things are part of a cosmetic rhinoplasty. So not all rhinoplasties are created equal. The difference here, which is the next thing we're going to talk about, is it covered by insurance? Yeah, functional rhinoplasty can be covered by insurance, but that doesn't mean that cosmetic rhinoplasties are. It's where you're changing the cartilages that the insurance companies care about, right? They don't want to pay for your self-esteem issues. They don't want to pay for your cosmetic preferences, how you want to fix your nose, how you want it to look. They don't think that should be a burden on the public dollar. So Lee, do you talk to people about functional rhinoplasty? Because I know you do a lot of laser work inside the nose that doesn't require a surgery.
Yeah, so here's what I tend to get, and I'm interested to hear what you say about this and how you address this. So I'll get, for example, an older patient whose tip has rotated down over time. They've developed progressive nasal obstruction. When I do this, all of a sudden, they can breathe beautifully. And or patient that has had previous trauma to the nose where the nasal bones have been crushed in on the septum. So it's actually the crush in of the nasal bone that's causing the nasal obstruction. So now you have a patient that needs a type of rhinoplasty to get that tip back up where it needs to be in order to open the nasal valves and get them breathing again. You need to break the bone in order to get the bone out where it needs to be. You present that to the insurance company. The insurance company says, heck no, that is a rhinoplasty. We're not paying for it. What do you do?
Well, quite often, actually, it doesn't fall under cosmetic rhinoplasty because what you're doing is a closed reduction of a nasal bone, which is covered by insurance typically. And then, there are a lot of ways to deal with Ptosis. Most of the time, this tripod, a la Jack Anderson, the tripod here has fallen off the end of the septum and is now hanging down. And you can take not just the skin, but the entire SMAS envelope, the thicker tissue underneath the skin. You can do an ellipse of skin up here in a scar revision and just raise the entire nose up. It takes you 10 minutes to do.
Yeah, but doctor, I don't want a scar on my face.
Well, it has to be closed properly, right? I mean, and so if this is from age, I guarantee you that if you get it up in here where there are horizontal lines, you won't see it at all. I don't have any problem with it being seen, even in close-up photographs. To answer your question, though, that's one way to have it covered by insurance in a very simple way, easy to recover from. And then you don't have to open the nose up and do a lot of complex things that maybe blur the lines between cosmetic and functional.
Yeah, the tip I usually, in that case, I'll deal with just when I do the septoplasty, I'll just create a Columellar strut and place in a strut of cartilage here that holds and pushes the tip back. Pretty easy thing to do. Takes an extra 5 minutes. So I'll do that, and then sometimes I'll actually suture the end of the septum to the Columellar.
And obviously you don't charge them for that. That's all under the same moniker of septoplasty.
No, just do it all under the septoplasty.
So you're doing something for free.
Yes, absolutely.
Because that is a cosmetic procedure. A Columellar strut is a cosmetic procedure.
Yeah, but I'm doing it for functional purposes. I've tried. I can never get insurance to say okay.
No, they won't. Why? And you're doing it for free. So to a certain extent, it's a little counterproductive. But because it takes you 5 minutes and no sweat off your nose, and the person gets a great result, you do it. And I think a lot of times, this is a whole other issue. A lot of times, docs do that because they care about the outcome, they care about the patient, they care about the word of mouth. And I think insurance companies know that, so they're just going to let you do it.
And I can do that because of my training. The average ENT wouldn't even know what to do.
Can't do it.
Right?
Or a tongue and groove, like you can do. Like I think you do it also. A reverse tongue and groove through a full transfixion incision takes 5 minutes. I do it all the time, and it looks fantastic. But it's just a septoplasty. But they come off looking so much better, so much straighter. Those foot plates are now hugging the septum. They're not bulging out into the airway and causing obstruction.
Exactly.
And we never get paid for that.
No. Yeah. Look, a perfect example is a Goldman septoplasty. Very, very intricate septoplasty that you do. Changes when you have the Columellar off, when you have a very bad front part of the septum deviation. These are very, very complex. They're really cosmetic procedures, and you're not going to get them through. And that brings us to the next question. The next question is, doctor, I can't breathe through my nose, and my nose doesn't look good. I want a rhinoplasty, and I want the insurance company to pay for it.
Or it's more subtle than that. It's like, doctor, I think I had a broken nose when I was 15 because my nose suddenly had this hump here. Is there a way that we can just take that down because it was from a broken nose? I don't have any records for it, of course, because my brother did it and we just sort of left it alone. But I saw these right around the time that I was getting my period. I noticed that these lumps came up right here, and they were never there before. So clearly it was that hit to the nose. Can we just shave them down a little bit? And that's part of the procedure, have insurance pay for it. Those are two takes on something that we see all the time.
So what's the answer?
The answer is it depends. No, the answer is no. They're not going to pay for it. I can tell you that if I start, because we have to do dictations. And years ago, there were some unscrupulous docs who, because there was a lot of money involved in septoplasties, was fairly similar to what they were charging for cosmetic rhinoplasties. They say, "Oh yeah, you broke your nose," or "Oh yeah, it's deviated," and they'll do it for you for the insurance money. We don't do that. what I do and what Lee does for cosmetic rhinoplasty is very complex, and we have to document everything. There's a meticulous sort of chain of custody to deliver you to your results, and we don't want to compromise that by lying. Okay, that's the wrong way to do this. And so if I dictate what I did, which I should, right, legally, then when they see that I'm carving down the humps, these are lateral nasal horns. They came up because of puberty, not because Johnny bumped you or kicked you. And so, or if I'm tailoring these tips or putting a tip graft in, those are very obviously, to anybody reading or scrubbing or botting your dictations, that's very obvious that you're doing a cosmetic procedure. There's really no functional counterpart to those moves. So then the insurance company is well within their right to say, you know what, this whole thing is now not getting paid for, and you're going to be responsible for the whole thing. Now it's an argument between you and me. So we choose, as scrupulous, ethical docs, we choose to explain to the patients right up front, look, there's some overlap here, and so on surgical time, you may save a few bucks on anesthesia because part of it will be paid for by insurance, part will be paid cosmetic. But any of the cosmetic stuff that I do, you're responsible for. That's just the way it is. That's reality.
And that's the way it should be done. So, Dr. Ben, what's the difference between a general surgeon that does rhinoplasty and a facial plastic surgeon that does rhinoplasty?
Great question, Lee. So the general plastic surgeon is just what it sounds like. And the training's different, right? General plastic surgeon does 1 or 2 years of general plastic surgery. I don't know if there are any programs that do full general plastics anymore. Usually 1, 2, or 3 years of general plastic surgery, and then they go into a 3-year program, 3 to 4 year program of plastic surgery. So they do general surgery and then plastic surgery. And the plastic surgery is very varied. In academic programs, it often entails flaps. It's very intricate, microvasculature, reconstruction and trauma, hand surgery, you name it. So they get a smattering of everything all around the body. When you start to talk about the face, quite often it's whoever your mentor is at that academic institution. So if you have a great rhinoplasty surgeon, like the folks up in the Dallas area, Rod Rourke and those folks, they have an amazing fellowship for specifically for the face and the nose. The Dallas Rhinoplasty School puts out its own books, in fact, and they have 2 to 4 week courses where a general plastics guy who's never really done a lot in the face can go to learn the nose. And therein kind of lies the problem. Facial plastic surgeon, right? Facial plastic and reconstructive surgery. We do 5, 6, and even 7 years specifically in the face, and then do another follow-on fellowship where we deal with very, very intricate, tough problems in tough patients, specifically in the nose and the face area for rejuvenation and reconstruction. So you're talking about a swing of at the very bad end for general plastics, a 2-week course where you learn a little bit. You're a great surgeon, fantastic surgical experience, but in the nose, not so much, right? Whereas I come out of University of Washington, just say, with an incredible knowledge base, not just of head and neck surgery, but specifically plastic surgery with the guys that were up there, Craig Murakami and Sam Most at the time, and also Wayne Larrabee. So, and then I went and worked with Calvin Johnson. So by the time I hit the road and tackle my first patient as an attending, I've had arguably 8 years of intense work in the nose. So I think it's a very different starting point. 10 years down the road, we might both look the same, but certainly that trajectory is very different. The starting tools that we have are very different.
Yeah, I have similar experience. The general plastic surgeons that I usually speak with will tell me that they really didn't have any hands-on experience in rhinoplasty in their even in their fellowship training, and they kind of learned it on the job afterwards. In my residency alone, I did 50 rhinoplasties, and then in my fellowship, did more than 100 more. So I think the familiarity with the nose, and especially the functional aspects of the nose, which the general plastic surgeons don't get at all, is really much better in facial plastic surgery. So I want to get to one more thing before we wrap it up, and that is, Doctor, I went to Dr. So-and-so, and he said he didn't have to make an incision to fix my nose, and you're telling me you have to make an incision. Why?
Well, you do have to make a decision to make an incision. But you know, look, there are many different ways to skin this cat. It used to be there was a big argument back in the 70s, 80s, even 90s about, do you open the nose, do you not open the nose? Calvin Johnson and his cohort, Dean Toriumi and some of the other, Dick Webster, Jack Anderson, they started to realize that through this progression, that opening the nose gave you much more precise control over grafting and things like that. And so a group of people, myself included, grew up, if you will, feeling comfortable opening the nose. More importantly, anyone can open the nose. Can you close it perfectly without any indication that there's an incision there? Yes, you can. So there used to be an argument about it. Now, I think with the proliferation of really good techniques, both in preservation rhinoplasty and closed rhinoplasty, where really it matters what you're good at. So I have no problem doing a closed rhinoplasty, meaning I don't make an incision here. I'm not as good at perfectly placing grafts, so if I have to do some grafts on the front of the nose, I open it, because I know that the person that I'm doing this on is not going to be able to tell the difference whether I opened it or closed it 6 to 12 months from now.
I think the important thing is that you said is that there is more than one way to skin a cat. Some people are more comfortable doing things without making an incision and can do a very, very good rhinoplasty that way. Other people are more comfortable opening it and can do a very good rhinoplasty that way. I don't think that should be the difference between you're using one person versus another.
Well said.
So what have we learned today? We've learned rhinoplasty is a change in the external appearance of your nose. It's usually someone doesn't like the way their nose looks, and so they want it changed. There are functional reasons, nasal breathing, that can be used in order to change the shape of the nose, but those are purely functional, and the purely functional ones generally may be available in terms of insurance reimbursement. But generally speaking, rhinoplasty is not covered by insurance. We know that it can be a relatively simple procedure versus a very, very complex procedure. And sometimes we don't know the answer to that until we're in there and we actually see what's going on. We've talked about how long it takes to recover. It can take a year to notice all the changes in your nose. And we've gotten a really good idea as to the complexity that the surgeon goes through in identifying patients, talking to patients, finding out if there are any psychological issues that are going on that could be impacting the decision to do rhinoplasty. So thank you so much for joining us today on our talk about rhinoplasty, and we can't wait to see you next time on Vital Discourse.
Your nose knows.